that works, yeah?
Yeah.
Is it in presentation mode? It's
She'll
okay.
do it. That's
Okay. Okay, hello everyone. Thank you all for joining us today. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I want to welcome and thank you all for tuning in. My name is Aline Serfari. I'm an MSK radiologist in Rio de Janeiro, Brazil. And I'm here today with Dr. Hilary Humans, who coordinates and moderates this series with me. Our guest speakers today are Dr. Kai Herman from Germany, Dr. Alexia Lopes from Brazil, Dr. Catherine Petchrapa from United States, and Dr. Ivona Sudol-Zopinska from Poland. The presentations today will be recorded and available on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. So if you want to join the OCAD community, consider registering on the OCAD website. All you have to do is write ocadmsk.com and register. I'm pretty sure you all will love it. This session will focus on rheumatology. The speakers will present their cases, and at the end, we will have a Q&A session. So if you have questions at any time during the presentations, please put them in the chat box, and at the end, we'll respond to them. Just a quick reminder, like I say in every session, attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you all for your understanding, and I will kick off the session. So we have the pleasure of having here today Dr. Alexia Lopes. She's a board-certified MSK radiologist at Clínica Axial do Grupo Aliar in Belo Horizonte. She graduated with a degree in medicine from the Federal University of Minas Gerais, and she completed medical residency in radiology and diagnostic imaging at Hospital do Ipeceng, also in Belo Horizonte. She did an MSK fellowship at Duke University and also a fellowship in sports medicine at La Sauvegarde, in Lyon, France. She has authored and co-authored original research on book chapters in MSK radiology. And with that, please, Alexa, take it away.
Thank you very much, Eileen, for your kind introduction and for the invitation. I'm very happy to be here today. I want to share my screen right now. Do you see my screen?
Yes, I see it.
So let's get started. My case is about a 7-year-old male celiac patient complaining of bilateral aching of hip girdle muscles, morning stiffness, malaise, weight loss. He had no history of trauma, diabetes, or fever, and any physical activity for him was an effort, and he couldn't find a comfortable position at rest. So pelvic MRI was requested. So as you can see here on coronal and axial stir images, there is a diffuse soft tissue edema around the hip joints in a symmetrical way of distribution, delineating the myofascial planes and adjacent to the proximal rectus femoris attachments, the indirect and direct heads at the anterior inferior iliac spine and supraacetabular ridge. Peritendinous edema is depicted around the attachment of the ellipsoas tendons at the lower trochanters, around the hamstring origin at the ischial tuberosities, and also as you can see here, adjacent, involving the adductor muscles adjacent to the pubic bones, also surrounding the capsules, delineating the myofascial planes. And what stands out the most is the thickness of the capsule adjacent together with the huge edema in the soft tissues. Well, to wrap up what we've seen so far, I think that the clue of the diagnosis is the edema pattern, which is bilateral, symmetrical, in a reticular, myofascial, peritendinous, and pericapsular distribution in the pelvis. So we're facing a case of polymyalgia rheumatica, PMR, abbreviated PMR, is a chronic inflammatory autoimmune condition in the elderly patients. Women are 2 times more affected than men. Patients often are older than 50, 55, with a mean of 70 years. They complain of pain of shoulders and hips, neck, and lumbar spine. Since it's an inflammatory kind of pain, it's unanimous, the morning stiffness, often more than 60 minutes, and the elevated ESR and reactive C protein. So the lab test, the inflammatory markers are abnormal, often elevated. In 10%, they can be normal, by the way. And what makes patients so happy and thankful to the rheumatologists is that they have a rapid response to low-grade steroid therapy. So they go crazy about their rheumatologists. This is the good news. But the bad news is that this disease is related to giant cell arthritis. So it has its neurological implications. So it's very important to follow this patient during the treatment. It's a long-term treatment, by the way. Another systemic features are weight loss, low-grade fever, difficulty in performing the daily routine activities. But this patient, however, they don't have muscle weakness, they don't have muscle atrophy. So the muscle strength is normal. So this can help rheumatologists in the differential clinical diagnosis. Well, the pathology of PMR is still evolving, the precise nature of this disease. There is great evidence based on imaging studies that this is a myofascial inflammation of connective tissues, of tendons and muscles that stands to the joint capsule and then ultimately reaching the joints as a joint synovitis. But there's still a lot of study to be done. What are the mimics of PMR? For you to, rheumatologists, they feel very comfortable. They ask a lot of lab tests, and this lab test will help in this differentiation, because we have a long list of differentials. But I'd like to call attention for these 2 diseases, which can be very confusing with PMR, which is the low onset of rheumatoid arthritis and spondyloarthropathy. So we have to be very careful about these 2 diseases, because this can be confusing sometimes. Lab tests will help us out. Well, the algorithm so far for rheumatologists is right away, but I think that we, as radiologists, we could add value with imaging studies in this diagnosis. How can we do that? I hope so. Back in 2013, 2015, Mackey and colleagues, they show a subset of patients with diagnosed PMR who had the characteristic symmetrical extracapsular and pericapsular edema pattern of MRI inflammation. They also graded the cases. So exactly the ones the pattern I showed you, in my case. Afterwards, there was this paper from Laporte and colleagues that emphasized exactly the same pattern of edema tissue, edema pattern of edema around the tissues in the pelvic and in the shoulders. And more recently, this German paper from Fruth, I love this because he could show that there is a 100% sensitivity and a 97.5 specificity of enhancing gadolinium, because the gadolinium was seen in the rectus femoris origin in the adductor muscles at pubic bone. And if we have 3 more other sites of inflamed tendons, so we reach this rate here. So that's good news. I think we are on the right track of the disease using imaging, especially MRI imaging. This is a case I brought, one of my cases that I have during the pandemic. I had a lot of cases during the pandemic, by the way, that shows the same pattern of contrast enhancing. In the literature, in the last years came out a lot of articles. So there's a lot of study to be done, to be learned about this disease. If you feel like studying that. Well, the whole of imaging in PMR, so a gold standard diagnostic test is still lacking, unfortunately. We are getting there. Ultrasound is capable to visualize both joints and periticular tissue. It's a low-cost diagnostic method. It can help also in differential diagnosis with RA, so it's good to know this. I don't have any experience with ultrasound, but the papers say that it's real good. MRI can displays a characteristic pattern of inflammation in pelvic tendinous and capsular structures, as I could show you in these examples from the literature and from my index case. And I think that we can potentially play a role in the diagnosis and management of the disease. And I'm pretty sure and very confident that we can add value to clinical and lab findings. Whole body MRI and PET-CT can help detecting multiple sites of injury, but it's still in study. PET-CT is important to detect vasculitis, so it's a complication of PMR. We'll see in the future. What I'd like to leave as key messages is that multilocular peritendinous and pericapsular inflammation are the hallmarks of pelvic involvement in PMR. It seems to be that's the point to get into the right diagnosis. We are on the right track, I think so. And the papers do too. The inflammatory pattern in pelvic MRI could serve as a confirmatory image test for PMR. We hope so, as radiologists in our daily routine to add in information for our rheumatologists colleagues. I thank you very much. Sorry, I apologize for any inconvenience. So I think that's it. Thank you so much.
Thank you, Alexia. Hi, everybody. I'm Hillary Humans. I'm a musculoskeletal radiologist in New York. I am the administrator of OCAD. Check the chat if you want to access the website or join the Google group for the email cases, which are usually almost every single day. I have the pleasure of now introducing Catherine Petchrapa, who is a respected and published associate professor at New York University Langone Health, which is part of the New York University Grossman School of Medicine. She's a little shy. Her bio, which she provided, is rather brief, even though we said a brief bio. All she could divulge is that she did her residency training at Brown University in Rhode Island and her fellowship at Mass General Hospital in Massachusetts. She listed her special interests as hand and wrist imaging, hip imaging, arthritis imaging, and she was a little embarrassed to admit that she enjoys DEXA. Okay, I have to let you know, Catherine is hard at work at the hospital and there is no video feed, so we'll have to imagine what she looks like. So Catherine, share your screen. Teach us something.
Hi from New York City, and thank you to both of you and the OCAD leadership for inviting me to present this case this morning. So our case is an 80-year-old woman. She presents with tendon ruptures in the left hand. She was diagnosed with lupus 20 years ago based on a positive ANA, photosensitivity, and a decade of arthralgias in the hand and feet. She suffers from interstitial lung disease and Raynaud's phenomenon, and many of her serologies, including rheumatoid factor and anti-CCP, are negative, and she has normal complement levels. According to her medical record, between 2013 and 2022, she presented with pain in the right and left hands with that waxing and waning picture very characteristic of lupus arthritis, and it seems to respond to medication. Despite having seen the same rheumatologist in our institution for decades, there really aren't many radiographs in her jacket. These are radiographs in 2016, and at this time there isn't much deformity, but we can see that there is soft tissue swelling centered over the second and third metacarpophalangeal joints of the right hand. At her current presentation in 2022, she shows gross deformity of the right hand. She has ulnar drift of the second through fifth digits of this right hand, and she actually has probably some small erosions here at the metacarpal heads. On the left, she doesn't have much soft tissue deformity or swelling, and this is the left is the side that she's currently presenting with. Here are some more images from 2022. This is the oblique and the lateral view, really highlighting the deformity, which is much more pronounced here on the right. This is her MR, and it shows that she has rupture of the extensor tendons here, likely the third, fourth, and fifth, and what is probably some synovitis at the wrist, which we're just catching at the field of view, at the edge of the field of view. The second patient is a 16-year-old who presents with progressive hand deformity and disability. She was diagnosed with lupus at the age of 8 based on a number of abnormalities related to multiple organ systems, including a discoid rash, long-standing arthritis. She also has a positive ANA. She's positive for anti-double-stranded DNA. She has low complement levels. And over time, she developed end-stage lupus or advanced stage lupus arthritis, as well as chronic arterial hypertension, anemia of chronic disease, and antiphospholipid syndrome. She too hasn't been imaged much since she had the diagnosis. This is an image of her left hand that was done for bone age. And you can see there isn't much deformity in 2017. And despite having long-standing arthralgias, we only have images of the hand from 2019 and 2021, which show this progressive deformity of both hands. On the left, we can see that there is ulnar drift of the digits. We can see multiple boutonniere and swan neck deformities, which become much more obvious on the lateral and oblique radiographs. And this is what she looks like clinically. She came in for MR of the left hand because of pain over the fourth metacarpophalangeal joint. And despite her only having one symptomatic joint, her MR images show diffuse extensor and flexor tenosynovitis. She has patulous joints. Here's the metacarpophalangeal joint with palmar subluxation of the proximal phalanx at the metacarpophalangeal joint. And here we can also see the hyperextension at the proximal interphalangeal joint and the flexion here of the fifth digit at the distal interphalangeal joint. She also has dislocation of the extensor digitorum communis tendons on the ulnar side of the metacarpal heads. And when you look carefully at the edge of the film, we can see that she's got some erosions at the level of the wrist. So today I wanted to talk a little bit about lupus arthritis, and I'm fortunate to have the ear of our fellow MSK radiologists in Brazil, where most of the work and research has been done, and from whom I've learned a lot in preparing this presentation. Lupus is a complex autoimmune disease with variable clinical features. It presents with a very complex, it's a complex autoimmune disease with very heterogeneous presentation and not a very clear pathogenesis. There's no definitive diagnostic test, although one of the entry criteria is being positive for antinuclear antibodies. And the rest of the diagnosis is made based on the other organ systems that are involved. It's a multi-system disease which involves many critical organs, and inflammatory arthritis appears to affect nearly all patients with lupus, but it's considered a relatively minor aspect of the disease. And perhaps because of that, lupus occupies a very small space in most radiology textbooks and review journals. The most common manifestation of lupus involvement is arthralgia, and it's joint pain without clinical signs of synovitis. This is a non-deforming and non-erosive arthritis that rheumatologists usually don't image and they treat clinically. Once a deformity is present, the arthritis is diagnosed based on clinical exam and the presence of and number of deformities. And then by plain radiographs to look for whether or not erosions are present. And that helps the rheumatologist divide patients into those with Jacquard's arthropathy and those with lupus. Jacquard's arthropathy is the paradigm that we're taught in residency. It is the deforming non-erosive arthropathy that affects 3 to 15% of patients with lupus, and they present with rheumatoid-like deformities of the hands and feet, including swan neck and boutonniere deformities, Z deformities of the thumb, ulnar deviation of the digits, and hallux valgus. And at least early on in the disease, these deformities are reducible. There's a lot I didn't know about this disease until I had to prepare for this presentation, but it seems that the cause of this is due to low-grade synovial or capsular inflammation, and this is leading to ligament and joint capsule laxity, tendon sheath distension and deviation, and muscle imbalance. Now, the synovitis that's present in lupus is mild compared to that of rheumatoid arthritis, and there is no pannus. And joint fluid analysis shows less intense inflammatory infiltrate than rheumatoid arthritis. The cartilage is reported to be macroscopically normal, and tendon rupture is reported to be rare, but it's most likely underestimated. Now, lupus on the other end of the spectrum is another paradigm. It's the coexistence of lupus and rheumatoid arthritis, or an erosive subset of lupus arthritis. It's rare and it's not well understood, and many people will say it's a debated condition. The prevalence is 0.01 to 2%, and there isn't any real established criteria, so it makes it difficult to really do studies on this. Some of the most strictest criteria come from the organization, the SLICC and the ACR-EULAR criteria, which require that, that they fulfill the criteria for lupus, as well as having erosions. They must be positive for rheumatoid factor or anti-CCP, and have other positive autoantibodies. Now, advanced imaging, I think, has shown us a lot about what's going on with lupus patients. And it turns out with those with arthralgia, who have the non-deforming, non-erosive arthropathy, studies are showing that MR and ultrasound are showing that these patients have subclinical inflammation. And this is in the form of tenosynovitis, synovitis, and sometimes even with erosions, even when they're not having joint symptoms. With Charcot's arthropathy, this is a non-deforming, non-erosive arthropathy, but imaging is also shedding a light on what's going on in those joints as well. This is just one paper of a study of 20 patients, which shows synovitis, erosions, and tenosynovitis in a large proportion of their patients. And they found that the tendon pathology is responsible for swan neck deformities and ulnar deviation in greater than 60% of these patients. A systematic review of ultrasound imaging in lupus done in 2015 looked at over 1,000 joints and also found the same thing, that there's quite a bit of inflammation going on inside the joints and around tendon sheets in these patients, and even though many of them with erosions. So all of these sort of support the idea that even patients without joint symptoms or changes on physical exam show imaging findings of inflammation in the joints and tendons. And those patients who are symptomatic do tend to have more abnormalities on imaging than those that don't. So it brings us to the Rupus category, which is, like I said, believed to be the coexistence of lupus and rheumatoid arthritis, although some are beginning to believe it may be an erosive subset of lupus arthritis. This is the reason why there is this idea that there is lupus is because lupus and rheumatoid arthritis are thought to be two different diseases because they come from different immunopathologic mechanisms, at least for now, and they technically have different targets, at least initially. And because autoimmune diseases overlap commonly, this idea of lupus is out there, although some people really don't believe in it too much. Now, the more imaging we do, the more we realize that bone erosions are actually present in patients who don't have bone erosions on X-ray, which is really what rheumatologists are basing their diagnosis on. And if bone erosions are present, this may indicate a more aggressive phenotype of lupus arthropathy, and that will have important implications for treatment. Garden variety lupus is usually treated with NSAIDs, with low-dose steroids, methotrexate, and antimalarial drugs. But in 2019, EULAR and ACR suggests the use of immunosuppressant drugs and biologics for those with rheumatoid-like moderate arthritis. So a little bit more aggressive treatment of these patients if you see anything that looks like it may be more rheumatoid-like or erosive-like. And so in summary, the take-home points here is that imaging is challenging the traditional paradigms of lupus arthritis by demonstrating a lot of this subclinical disease and also revealing the abnormalities such as erosions and tendon ruptures and synovitis, which were not in the original description. And these are important things for us to report because these aspects of the disease may signal a more aggressive type of disease that requires much more aggressive treatment. Thank you very much.
Thank you, Catherine. That was fantastic. Now, it's my distinct pleasure to introduce Professor Ivana Sudol-Sapinska, MD, PhD, who graduated from the Medical University of Warsaw and obtained specialization in radiology in 2002. She's the head of the Department of Radiology in the National Institute of Geriatrics, Rheumatology, and Rehabilitation in Warsaw. Since 2012, she's an editor-in-chief of the Journal of Ultrasonography, which is an official journal of the Polish Ultrasound Society. She's been supervisor of 14 PhD postgraduate students. And from 2015 to 2018, she held the function of a chairperson of the Arthritis Subcommittee of the European Society of Musculoskeletal Radiology. She organizes MSK courses and conferences dedicated to MSK imaging and sports and rheumatology, of which I've had the pleasure to participate. She's authored or co-authored more than 280 articles in peer-reviewed journals and edited or co-edited 30 chapters and 6 monographs and gave a number of invited lectures. Fortunately, she's taken time out of her busy vacation schedule in rainy Spain to join us this morning. Okay, Ivana, share your screen.
Wow. Right. Right. Thank you, Hilary. Can you hear me, please? I have unstable connection.
Yes. It sounds perfect.
Okay, thank you. Thank you very much, Hilary, for this nice introduction. The case I'm going to present is gout. So already at the beginning, I am revealing you this secret, but the aim of my presentation is different, to show you how tricky that disease is in the first years, and also how the disease is progressing if the patient is not following recommendations. I will start from the introduction. Gout is the problem that we face in many countries because of the global problem of obesity. This is the most common non-degenerative inflammatory arthritis. It is the most common crystallopathy, and it is a metabolic disorder of purine metabolism characterized by the recurrent episodes of arthritis associated with the presence of monosodium urate monohydrate crystals in the MSK tissues. The hallmark of gout is hyperuricemia, and these crystals start to precipitate in tissues when a serum urate level exceeds 3.8 milligrams per deciliter. These crystal deposits that are seen in gout cause acute inflammation of the articular and para-articular tissues, whereas recurrent episodes of arthritis result in chronic gouty arthritis with cartilage and bone destruction. Left untreated, as you can see on these images, the disease can be really debilitating. Most patients with gout present between the ages of 30 and 60, and our typical patient is a 50-year-old man drinking purine-rich beer, eating purine-rich foods, and with metabolic syndrome, which is a cluster of at least 3 out of 5 following medical conditions: central obesity, high blood pressure, sugar, high serum triglycerides, and low serum HDLs. 90% of first gout attack is monoarthritis, mainly or most commonly of the MTP joints, followed by a number of other joints. In early gout, radiographs usually are negative. Very rarely we see tophi. Very rarely crystals close to the bone may lead to periostitis. But ultrasound and dual energy CT are very sensitive and specific. In ultrasound, we can see tiny crystals within the joint effusion or thickened synovium, then may create bigger aggregates, microtophi, then may create the double contour sign. In dual energy CT, we may see crystals here coded in green. However, it is not ideal method, and in the early stage of the disease, the amount of crystals can be really small, and that may be also negative. In chronic gout, everything becomes more clear. On radiographs, we will see asymmetric tophi. We can see erosions with overhanging edges with sclerotic fundus. We see normal bone mineralization, contrary to many rheumatological diseases. We may see osteolytic pseudotumors and pathological fractures following cartilage damage. Wow. In ultrasound, in chronic gout, we see tophi, which may have different echogenicity, well-defined, poorly defined, maybe vascularized, maybe non-vascularized. So they have different presentation, may lead to tender stairs, partial, or even complete. Dual energy CT, very powerful. Here, lots of crystals, so the disease confirms that these are monosodium urate crystals, and also provides quantification that is used to follow up the treatment results. And finally, MRI and CT, they are not used for the purpose to diagnose gout. This is the same patient, and you can compare how much crystals is injected in this patient and what can be seen on the MRI and CT. On MRI, we do not see crystals, and these are tophi. They have a specific signal on MRI and not very high density on CT. Now the case. Our patient has 51 years, is 51 years old. Gout was diagnosed in 1986. He has metabolic syndrome with obesity, hypertension, diabetes mellitus, hyperuricemia, following several hospitalizations. And images that I have collected are from years 2009 to 2021. Initially, during the first hospitalization, which was in 2009, foot radiographs shows only sclerotic cysts with sclerotic outlines and joint space narrowing. He is 42 years old. 42 years old. I'm trying to get rid, sorry, okay, to see my images. So it was 12 years ago in 2009. He's 42 years old. So foot radiographs shows lesions that looks like osteoarthritis, no specific features for gout. The same year, ankle radiographs show only thickening of the soft tissues at the right ankle. 2 years later, knee ultrasound shows tiny crystals within slightly distended lumen of the gastrocnemius semimembranous bursa that could be interpreted as a starry sky sign. 4 years later, in 2015, again admitted to hospital, worsening of symptoms, does not follow dietary recommendations, swelling, redness, joint warm, tophi, BMI very high, and all laboratory parameters of the inflammation are elevated, and also the uric acid level. He signed off on his own too. This period, we can see ankle joints with a number of tiny cysts with sclerotic outlines. Foot radiographs does not show any progression on the cysts with the sclerotic outlines, joint space narrowing, so like osteoarthritis. On hands, we can see contracture of the PEEP joint on the right hand and joint space narrowing, some sclerotization in the radiocarpa, scapholunate joints bilaterally. 3 years later, 2018, again admitted to hospital with the similar clinical scenario, so does not follow dietary recommendations, BMI even higher, treatment with even specific for gout drugs is not successful, and still high inflammatory parameters. Now, 9 years from his initial radiograph, we can see progression. So there are tophi in this patient in several locations, and in addition to this cyst joint space narrowing, we have already some erosions. Hence, in 2015, this image you have already seen, there was only some contracture, and 3 years later, we have contracture in these two joints, and this arrow shows tiny erosion with some sclerotization, some overhanging. Altogether, everything starts looking like gout. Ultrasound, very much specific. This is a tophus. This is the joint space with tiny crystals and bigger aggregates. This tophus is well defined. This is an amorphous tophus compressing the median nerve. And the last set of images, 3 years later, 2021, again, hospitalization in December 2021, so several months ago. BMI high, all these parameters of inflammation, uric acid, everything is elevated, cholesterol, also triglycerides. So now we can see more tophi, at the wrist level with tiny starry sky sign, with aggregates. This tophus, for example, is well defined, but without any vascularity. So they have different presentation. They might have halo. This one doesn't have. On this previous radiograph of hands, we had such presentation. Now there is more contracture in this patient. Why? Let's move to back to 2019. In 2019, we both DECT, and then we can explain why there is a fracture in it, because this is the palmar side. There is lots of crystals, probably in the tenosynovium of the flexors of this finger. There is also lots of crystals in the Druid joint of the left hand, but here you can see that there is that these methods are not equal in presenting features. We do not see crystals on radiographs, on the soft tissue thickening, so soft part of the tophus. And now 2021, more contracture in these joints because there is lots of crystals, much more than 2 years before, at the level of the joints, at the level of the tenosynovium of different fingers. And also he had chest DECT. Here you can see a number of crystals in the posterior ribs, and also in the costotransverse joints, and also in the intervertebral discs. There is some literature about DECT in the spine. There are physiologic deposits of the costal cartilages, but these are posterior bony ribs and intervertebral discs. However, other publications say that location of the crystals in the cartilage of the intervertebral discs may lead to myelopathy and spinal pain. This patient also had MRI, and all these low signal areas in the patella tendon, in the patella retinaculum, iliotibial tract, in the biceps tendon, in the medial compartment, also in the cruciate ligaments area, they all represent tophi. So in conclusion, in early gout, radiographs are usually non-specific, and radiographic changes are seen only after 6 to 15 years from the disease onset. This is the initial radiograph of this patient, with cysts, with sclerotic outlines, with joint space narrowing. He is quite young for osteoarthritis, so probably there are already crystals there that led to cartilage damage and intraosseous damage of the bone. In early gout, ultrasound and dual energy are most sensitive and specific, and there are currently large opportunities for improvements with regard to early detection and initiation of urate lowering therapy, but still the patients need to follow recommendations. The list of references is long. This one comes from the paper of James Tay, from the seminars in musculoskeletal radiology. This issue was in whole dedicated to rheumatology. This year, month, published a radiographic atlas of inflammatory rheumatic diseases. It contains almost 500 radiographs, high quality radiographs with a very detailed figure captions, so a very educational position. So if I can, I would like to recommend this book. And so thank you very much for your attention.
Thank you, Ivana. Fantastic. Can you hear me?
Yes, thank you very much, Elaine. Thank you very much, yes.
Because the internet here is not good today. Anyway, so it's my pleasure to introduce Dr. Kai Herman. He's a professor of radiology specialized in musculoskeletal imaging with a focus on arthritis. His research is dedicated mainly to axial skeleton, but the peripheral joints as well. The majority of his research projects are in the field of spondyloarthritis, where he's also connected with other research from Canada, Brazil, UK, Germany, and Israel. He has also a strong track in applying innovative technology within medical education and is leading the team behind the Berlin Case Bureau app. He's an active member of ASAS, ISS, CSSR, DJMSR, and DRJ, and has won the Comrade Wilhelm Röntgen Award in 2011, Felix Washman Award in 2014, and DVMB Research Prize in 2015. In 2019, he was promoted to associate professor. Please, Kai, share your screen. Take it away.
Thank you, Alini, for the introduction and for the for trying to speak these German names.
Yeah.
Very nice, very nice. So I will share my screen, and here we are. So I will now present you today a case that, can you see on my screen and can you hear me? Okay.
Yeah.
So I today will present you a case that overlaps a lot with our colleagues from dermatology. So this patient came to us over a period of time, and the diagnosis was not clear from the beginning, and we had a lot of differentials that we were thinking about. And on initial presentation, this patient came as a 35-year-old woman. She's a housewife and a mother of 5 children. And she came with arthralgia in most of her joints, and those were already present for 4 years. So over the time, she also had developed fatigue and was really feeling sick, and it was increasing. So her family did pursue her to go to the doctor. When she presented to the rheumatologist, there was also severe pain in the hand and the finger joints, and also morning stiffness was reported initially. So when she was not yet visiting the doctor, it was about 2 hours and even longer. And later on, it was reduced to about 30 minutes. There was on inspection of the patient, there were some nodular and sometimes pustular skin lesions. They were sometimes also appearing as spot lesions without any elevation. Later, they also were presenting as vesicles with pus inside, but there was no fever or night sweating. There were no FT at the genital folds or oral folds. There was no psoriasis and also no hair loss. Lab tests did reveal an elevated CRP of 38 with a reference value of below 5, so it's rather elevated, but there was no rheumatoid factor, no ACPA antibodies, and also I think no EB27, but this was not tested at the beginning. Later on, she returned after 2 years. So there were some initial thoughts on differentials, and there was some initial medications given, but the patient didn't show up again. And after 2 years again, she showed up again to seek doctor's advice. And then the disease had deteriorated. So there was now pressure pain in almost all joints. There was swelling, severe swelling in the PIP joints and DIP joints on the second and third fingers on both sides. So it's rather symmetric. And there was also swelling on the wrist, but only on the right side. And there was even swan neck deformity developing on her second finger on the right side. There was also some dactylitis on the toe. And CRP was still elevated, but not so high. And it was now in the range of 12 milligram per liter. So let's look at the images. I will present the images in the Berlin Case Viewer app. As we have already heard, that's an app that we developed here in Berlin. And this is an app to show cases, to learn with cases, to learn on interesting cases and also rheumatic diseases. So this is the skin lesion that the patient did present. So that's it's about her abdominal wall. And as you can see here, there were some lesions on the skin, reddish, patchy skin, but not so much as an elevated lesion. At that time, also there was some X-rays taken, and these X-rays, they look rather normal. So if you appreciate here the joint spaces, they look fine, and it's symmetrical on both sides, and also the DIP, PIP joints, they are fine. So then the patient returned, and then there was again this clinical picture, and the patient was referred to the dermatology department. So they made high quality photos of her skin and her hands. So here you can see there is some deformity of the second finger. There is also some papular skin lesion in the next vicinity of the joint, and it's even symmetric manifestation. So if you look here, both hands, there are these lesions next to the joint, and here you can also appreciate the swan neck deformity on the on both fingers, but most prominently on this second finger, as you can see here. And at the same time, also the patient presented with lesions in the axillary folds. So you can see here there are this reddish lesion in the axilla, and it really looks inflamed a bit, sometimes smaller lesions. And we were also not sure about this lesion over here. On going back to radiology department, we were then revealing their hands, and you can now see that there is some swelling here at the DIP joint. There also you see the joint contour is well preserved. There's no erosion, but there is soft tissue swelling, as you can see. And if you compare to the right side, similarly here on the left side, you see this deformity also here. And with Berlin-Käsfür, you can draw these overlays. So you can see there is this swan neck deformity, and you can learn how it looks on X-ray. Okay. And of course, we also performed advanced imaging, and we did perform an MRI in this patient. So our protocol consists of T1 weighted coronal scans, proton density weighted scans, and also here we did injections with gadolinium. So I will present all of those lesions. So this is the entire hand in the coronal plane. And you can see there is no erosive change, but you can see that there's already increased thickening of the synovium on the second PIP joint, and to a lesser extent also at the third one. And also if you're looking closely, you can see it here on the DIP joint, but DIP joints are always difficult to evaluate. Looking at the proton density weighted image, you see that there is in fact thickening with high signal in the DIP joints. It is present in the PIP joint. It's also present in some of the MCP joints, as you can see here, and also at the wrist. And I think it's always a wise idea to compare with the axial plane. And here in the axial plane, you can see that there is some tenosynovitis or peritime tendinitis at the extensor tendons. There is some flexor tenosynovitis in some of the palmar tendons. Here is more tendon sheath fluid, and comparing with the sequence after the gadolinium injection, you see that there is some inflammation near the joint, and it's in the dorsal position, but there is also tenosynovitis here. So that is the DIP joint involvement. And we have this three-dimensional wipe sequence where you can look at the joint no, we didn't do a wipe sequence. That's also a T1 fat saturated sequence. So we see the DIP joint inflammation, that's now gadolinium enhancement, PIP joint inflammation, we see the tendon involvement, and also interphalangeal joint involvement at the thumb and also at the wrist. And we did one additional sequence that we are not doing routinely, that is the sagittal plane, where you can see that there is this swan neck deformity and there's joint inflammation, also tendon involvement. Okay, so what can we make out of this? So when we were initially seeing these papillary lesions, we were thinking about some histocytosis, and there is the multicentric reticular histocytosis, and we sent the patient for biopsy taking of these lesions, and that didn't turn out to be histocytosis, but it turned out that this patient has hidradenitis suppurativa, how it is called in most parts of the world. In Germany, it's called acne inversa, and scientists working in dermatology told me that it's more like an acne type and less like an hidradenitis type. But this is how it looks in the pathogenesis. We have these hair follicles, and usually we have this sebaceous gland, and they get inflamed with bacteria and also debris of dead cells, and this triggers immune reactions and can lead to a very overexposed immune reaction, and at the end, this disease is an systemic disease and affects multiple organ systems in the patient. There is also a lot of research going on in terms of explanation of the disease and how it overlaps with other diseases, like for instance, psoriatic arthritis. We have seen in our patient, there was involvement of the DIP joints. DIP joint involvement is not so frequent, so more or less it never happens in rheumatoid arthritis, but it can happen in psoriatic arthritis, it can happen in gout, and it also can happen in multicentric reticular histocytosis. So there is some hypothesis that there's some overlap between acne inversa and psoriatic arthritis, and in fact, these two diseases, they also expose TNF-alpha at a very high amount, and also interleukin 17 and 22. All three of these cytokines are playing a role also in psoriatic arthritis. Both diseases can be triggered by mechanical factors, which is the friction in the body folds in AI or HS, and also the so-called Koebner phenomenon that you see in psoriasis. And also both of the diseases are said to have involvement of joints and the axial skeleton, and in fact, that might be the case in our patient. Acne inversa and hidradenitis suppurativa are associated with other diseases, for instance, spondyloarthritis, being it the axial form or the peripheral form. We also see overlap with inflammatory bowel disease, with metabolic syndrome, and also arteriosclerosis. There was one study done by Riquet about the frequency of musculoskeletal symptoms in patients with hidradenitis suppurativa. They investigated 640 patients, and about 35% of them have multiple musculoskeletal complaints, and even about 6% of them, they even have enthesitis and arthritis. Here's an example from a study that our colleagues did in 2016, where they evaluated the MRI scans of the pelvis before they had operations on their skin, because if there's a lot of skin involvement at the anus, then usually they do a MRI scan to search for sinus tract and fistula. And they could see that 56% of the patients, they have some pathological conditions at the lumbar-cervical junction, and 39% of these patients had even erosions and bone edema at the joints of the pelvis, for instance, at the sacroiliac joint. I think that's a very interesting fact. So in total, this patient has a co-occurrence of acne inversa or hidradenitis suppurativa with peripheral arthritis. The peripheral arthritis cannot be really explained by psoriatic arthritis, as there's no psoriatic skin lesions, but there are skin lesions of this other disease. So we are assuming this is a co-occurrence of both. And before I finish, I would like to show briefly the companion case that I mentioned, the multicentric reticular histocytosis. It's a really rare disease. I think Ivona will have seen it already, and it's something if you see erosions in the DIP joints and in the PIP joints and in some of the MCP joints, then you should think of this disease, which is also a disease that affects the skin and the bone. Okay, so this was my case. Thank you very much, and hope you enjoyed it. And of course, also, if you want to learn further, you can use our app to learn about musculoskeletal symptoms. Thank you very much.
Thank you very much, Kai, and all the speakers. There's a comment here. So great, from Brian Patterson, great discussion, Dr. Herman. Is there an auto-infectious component to these patients? Not sure where the research is currently, but Cutibacterium acnes was once blamed for a lot of skin joint syndromes in the form of Safel, the bacteria previously known as B. acnes. I would be interested in your thoughts about the overlap.
Yes, so I have to say that I cooperate with our friends from dermatology. So I myself are not so deeply involved in understanding the microbiological process of the disease, but I will certainly check it out after the session. Sorry.
Okay, thank you. I have a question to Dr. Katharina Petchrapa. So I put it in the chat. In cases in which rheumatoid arthritis and lupus are suspected to be overlapped, like the case you showed, what is the imaging workup at NYU? Do rheumatologists favor ultrasound over MRI?
I think it's very interesting because one of your invited speakers in the recent past was Jonathan Samuels, who's a rheumatologist at NYU, and his talk was on ultrasound of arthritis. There are some of our rheumatologists will do their own ultrasound in their office, and he is one of them. And certainly, I think this case would have benefited from some ultrasound. The rheumatologist who referred this case does not do ultrasound, so we are trying to do an ultrasound of his 80-year-old patient to look for active inflammation. But certainly, the literature does show that using power Doppler on ultrasound is very sensitive for the detection of active synovitis. So I can see why, especially in the hands, an ultrasound would be preferred. We do screening MRI too, which we would screen for both hands. I think, like I said, because because you can do both hands, it's very good for a screening tool to determine which sites are active. So I would say a little bit of both, but certainly in this case, ultrasound would be very helpful.
Okay, thank you. Is there any more questions? If you have questions, open your microphone or put them in the chat box. Also, Ivana is saying, Kai, excellent presentation. Never heard about HA and arthritis. Do dermatologists know that? It's in the chat.
Yes, so dermatologists are so they are, of course, are trying to educate dermatologists in the private practices. So our dermatologists they are quite elaborated on that, and I know they do also basic research for the disease. But I believe the regular dermatologist knows few about it, because our patient also was sent from one doctor to the other, and she's also from a Turkish background, so there was also this, yeah, you have to say, racist type problem that these patients have no good standing at the doctor. So that's really a problem.
Okay. So no more questions from the audience. I want to thank you all for tuning in. And we are all looking forward to the next session, which will be held on April 29th, with focus on pediatrics. So see you there. Bye.
Thanks.
Thank you all.
Thank you all. Bye-bye.
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 Bye, thank you.
Bye.